Welcome everyone to Grand Rounds. This was supposed to be a hybrid rounds, but our speaker has been stranded in Cape Breton due to the storm. And so he's not here with us, but the rest of us are here in the room. Before we get started, I would like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. So we are very fortunate today to have an outside speaker, a guest speaker, courtesy of the hard work of Rita Suri and the Division of Nephrology. And I will ask Rita to take over to introduce our speaker today. Rita, the floor is yours.
Thank you, Nadia, and thank you, PJ, for agreeing to speak to us today. So Dr. Devereaux is a cardiologist, perioperative care physician, clinical epidemiologist, and professor at McMaster University, where he directs the Division of Perioperative Care. He holds a Tier 1 Canada Research Chair in Perioperative Medicine, and through his career has received over $345 million in research funding. He is a world-renowned clinical trialist, and his work has had significant impacts on practice in the fields of cardiology and in perioperative medicine. He has published over 440 peer-reviewed papers, including 16 in the New England Journal of Medicine, 13 in the Lancet, and 11 in JAMA. He has given over 1,000 lectures and research presentations in 41 countries, and we are lucky to have him here today. Currently, he's the scientific director of the World Health Research Trust, a private not-for-profit research organization that is dedicated to undertaking global RCTs. And last year, he received a $39 million grant from CIHR to lead the Accelerating Clinical Trials Consortium, of which members of the Department of Medicine and the RI-MUHC are privileged to be a part. So I now turn over the floor to Dr. Devereaux, who will be speaking on his work, both related to the ACT and in conducting RCTs in perioperative medicine. PJ?
Thank you so much for the opportunity to talk today. I'm really sorry I can't be there with you. I was very much looking forward to it. I was telling Rita that our son finished his undergrad at McGill just this last year, and I've heard nothing for the last 4 years other than how amazing McGill is and how much you love the city. And anyways, I'm sorry I couldn't be with you, but I'm a Cape Bretoner, and Cape Breton, you may not know, but is getting a medical school. And so I joined the board of governors for the university, trying to help them out. And I was here last Friday for a board of governors meeting, and it started snowing on Friday, and it didn't stop until Monday morning. And this was my outdoor on our veranda coming out of our back, and then I opened up our garage, and this is what it looked like. And then this is after 6 hours of shoveling yesterday, so I told my wife I should expect to see her by about June of this year. Anyways, I'm really sorry I couldn't be with you, but unfortunately nature jumped in the way. So as part of our institution, I'm expected to put up my disclosure at the start of all my talks. Based on study questions I've written in grants, I've written and received grants from many different companies, all listed here. And I've participated in advisory board meetings, expert panels, international meetings for various companies, and consultancy work for various companies. So the goals of the presentation today is that I first want to talk about the Canadian trial landscape. I then want to give an overview of the ACT guiding principles and structure, activities to date and upcoming endeavors. And then I want to talk about just my journey in perioperative clinical trials and the work that we've done in this area. So research demonstrates that Canada punches well above its weight class in doing high impact randomized controlled trials. And you just need to open up the New England Journal of Medicine or Lancet any other week, and there's a reasonable chance that you'll see a trial led by a Canadian. And when you consider that our population is 0.5% of the world population, that is a remarkable contribution. However, it is also important to acknowledge that the COVID-19 pandemic uncovered serious issues related to the conduct of clinical trials in Canada. Successful Canadian trials have primarily occurred, I put forward, due to researchers having the mindset of a long-distance runner. Trialists have succeeded because of perseverance, not because of the system. And when COVID-19 happened, trialists had to function as sprinters, and the problem was there was barriers and operational bottlenecks that impeded trials being done in an efficient manner. And as a result, Canada didn't lead the world in doing clinical trials during COVID, despite having a very outstanding history of making great contributions contributions in trials. And we really became dependent on other countries like the UK, which conducted trials much more efficiently and established effective treatments to really turn around this disease that we were confronted with. And we should ask ourselves tough questions about, why did that happen and how are we going to make sure this doesn't happen in the future? So accelerating clinical trials, the ACT Consortium was funded in part to address these challenges. The central guiding principle of ACT is that our activities will accelerate, optimize, and facilitate the conduct, implementation, and results translation from high quality, high impact RCTs to improve health in Canada and around the world. This shows you our structure. So ACT sits on the Canadian Biomanufacturing and Life Sciences Strategy. So the federal government is investing $2.2 billion into biomanufacturing and biotechnology. They also recognize for the biotechnology they needed RCTs, and they're investing $250 million into RCTs. Most of that money is open competition, but also money went to fund a number of training platforms, of which there was 8 across the country, and one Pan-Canadian Clinical Trials Consortium, which was the ACT Consortium. The platform for the ACT Consortium is our 11 clinical trial units, geographically located across the country, of which McGill is one. And these clinical trial units have the infrastructure and personnel to conduct clinical trials. Sitting on top of our platform are pillars of research networks made up of researchers focused on different disease states, patient populations, and interventions. We have 28 networks as part of ACT that span from pregnancy all the way through to palliative care. And then cutting across our pillars, we have cross-cutting enablers, which are working groups trying to address a number of structural issues that exist in terms of impeding trials and how to optimize their conduct. Then we have our knowledge mobilization committee that sits on top of this, and overarching all of this is our governance structure. So the grant for ACT was announced on January 19th, 2023. We have established 22 committees and working groups with their co-chairs, members, and terms of reference. And these groups have now met over 200 times in the first year since we started. This shows you our committees, working groups, and advisory boards. So in blue is the committees that exist within ACT. The operations committee is the central committee, of which Louise Pilon from McGill sits on. We then have both the national and international advisory committee. And then we also have in yellow these working groups. We announced the first ACT request for applications RFA on February 27th. This was to support high impact randomized control trials that needed just a little bit of help to get to the goal line. The submission deadline was April 3rd. We had 43 applicants from 19 ACT networks, and we had a targeted peer review process whereby each applicant was reviewed and scored by 5 independent individuals who had previously led high impact clinical trials. We had 11 successful applications. This was announced on May 18th. Total funding was $2 million. And several of these trials have now been completed, published in New England Journal of Medicine, Lancet, and presented as late-breaking trial presentations. And some of them are already changing care, with most recently being Artesia, demonstrating that anticoagulation in patients with short periods of atrial fibrillation on their pacemakers benefit with a stroke reduction. This shows you the winners of the first RFAs. They came from diverse networks across the ACT Consortium. We had then the first annual ACT Consortium meeting on April 17th, 18th in Hamilton, Ontario. The focus was to discuss ACT's goals and structure and bring Canadian biotech and the trial community together. So we had 300 researchers attend, and we had 65 biotech companies attend. Each biotech company was given a 5-minute period where they could do an elevator pitch of their technology and address some questions. We also had lots of discussion about processes to move forward. And at this meeting, there was unanimous support to pursue a single national distributive REB approval model. We announced our second ACT RFA on April 11th. We had 2 streams of funding. Stream 1 was a non-traditional trial design, so not your parallel group RCT, but could be a cluster crossover, stepwise design or something else that was novel. And stream 2 was trials evaluating methods to improve the conduct of trials. So trials within trials. So looking at things from how do we improve recruitment of various groups of patient populations, how do we get better retention of patients in trials, etc. The submission deadline was June 8th. We had in stream 1, 33 applicants from 18 ACT networks. And in stream 2, we had 8 applications from 6 ACT networks, and each application was reviewed and scored by 5 independent reviewers. We had 8 stream 1 and 5 stream 2 successful applicants. This was announced on August 4th for funding just under $2 million. This shows you the stream 1 funded RCTs, again, spanning very diverse and broad areas. And this shows you the stream 2 funded trials, looking at trials within trials to improve the efficiency of trials. Another issue that ACT is trying to address is the democratization of clinical trials. Not everyone in this country has opportunity or access to be part of clinical trials, and we want to improve this. We want to create an equitable access to clinical trial participants by creating a portfolio system, which I'll tell you about in one moment, but also novel partnerships with pharmacies like Shoppers Drug Mart and hopefully other pharmacies that can actually start to help with recruitment of patients across the country. We also created a communication strategy, Be the Cure, which Emily McDonald is one of the co-chairs of, and this is a really important part of trying to make the population realize the value of clinical trials. Our national portfolio funding competition came from what was the clear success in the UK during the pandemic of the UK's portfolio hospital. The thing that allowed the UK to have the recovery trial done in what almost seems to be a miracle time period was that about 12 years preceding that, the government had invested to embed study personnel in all the hospitals across the United Kingdom. So once the investigators wrote the recovery trial, single national REB approval, single contract approval, and then that all happened within a span of 2 weeks. And then the next day, every hospital in the country were recruiting patients into the recovery trial because study personnel were embedded in every single hospital. That had an enormous advantage, and we see the incredible success of the recovery trial. We wanted to try to replicate this by starting a portfolio hospital system in Canada. So we announced this in February. We invited submissions from any community hospitals across the country. Deadline was April 14th. We had 41 applicants that had fill out a lot of information, send it in to us, and then we did on-site interviews with each one of the applicants and their centers. Review panel reviewed these, and we scored these applications. The results were announced on June 19th. We had 20 portfolio hospitals funded from 9 provinces and 1 territory. And this shows you the location of these portfolio hospitals from across the country. And this just lists the portfolio hospitals from within the country. We have 2 that were funded within Quebec, number 8 and number 9. Another issue that we want to try to do within Canada is to grow the funding research pie. We waste too much money, and I've been guilty of this myself, debating how we should divide up CIHR's funding pie between basically basic science and the other pillars. And this is not overly helpful, I think, in the end. What we should really do is figure out how we're going to grow the amount of funding that's available to us. I think we should learn from the EU. I've been involved with a number of funding opportunities in the EU where they gave very serious money to do clinical trials, but they required that you must bring in European biotech companies. And we should not accept that it's only Europe and America that has big pharma or big biotech. Canada could have that, but if we're going to have it, we're going to have to invest in our biotech companies and help them to grow. And as a community of clinical trialists, we have to invest in Canadian biotech by doing trials of Canadian biotech. So one thing is we need to bring the biotech world and our clinical trials together more, which was the first thing we attempted to do in April of 2023. And then we have to create funding opportunities for these biotech trials to be undertaken. We also want to help with international big pharma that wants to bring more trials to Canada. And the main impediment impeding that is just the inefficiency of trials in Canada. we are working in concert with them to try to address these inefficiencies and create more opportunity for more trials to be available to Canadians so that people can make choices for their own health. The third RFA was announced on May 11th. This targeted trials that would evaluate Canadian biotech. The submission deadline was July 7th. We had 30 applicants from 17 ACT networks. We had a targeted peer review where each applicant was scored by 10 independent reviewers, 5 biotech reviewers, and 5 clinical trialists. We had 5 successful applicants for a total funding of $2 million, and this was announced on November 3rd. This shows you the 5 successful applicants addressing lots of important issues. We held the second annual ACT Consortium meeting on September 21st and 22nd in Charlottetown, Prince Edward Island. The focus was introduce the portfolio hospitals to the consortium and integrate them into the consortium and get them involved with trials. We also had discussions on regulatory, and we were reviewing and understanding and commenting on draft ICH E6 revision 3 that's happening. And post the meeting, we then made a submission to Health Canada suggesting edits to this document. We also had breakout groups and discussions around a single national distributive REB model with clear review timelines, and we recognized and celebrated the first and second RFA winners. ACT is also trying to improve the process for involving Indigenous peoples in trials. One thing that became very apparent when we were designing the ACT consortium was that the Indigenous groups felt that too frequently they were just being asked to participate in something that was really not relevant to their health. And so we proposed to them to switch the focus and to first undertake research in their communities, the 3 communities of Indigenous people, so First Nations, Inuit, and Métis, determine their health priorities within their communities, and then specifically fund a trial in each one of those communities only to be conducted in those communities and led by an Indigenous researcher. And that's the work that we're doing right now. On reflection, a lot has been achieved in the first year. I want to first express a lot of gratitude for the co-chairs and committee members who have worked diligently towards ACT goals. And there's many people at McGill who are on these committees, and I'm very grateful for all of the energy and insights that you've provided. Thank the ACT networks and CTUs, the RFA reviewers and portfolio review panel, our partners, and our central ACT support team. I also want to acknowledge Louise Pilon and Emily McDonald, who both are on our ACT operations committee and play a very big role. Also, Louise co-chairs our scientific committee, and Emily co-chairs our communication committee, and they've made enormous contributions to ACT, and we're really grateful for everything that they have done. I also want to acknowledge Jean Bourbeau and Bruno, who are heading up one of the clinical training platforms, CanTrain, and playing a very important role at a national level to really improve the amount of people who have training and access to this. Also just want to acknowledge 2 other people who played important roles within our committees and one of our networks. So Shushmita and Todd, who Shushmita is on our clinical trials unit committee, and Todd heads up one of the networks on infectious disease. Again, there's many other people in McGill also involved, but I just wanted to identify a few people who've played very large roles. Our current endeavors is that we have just received all of the applications for our RFA 4, which is funding for new networks in an area of need. We had 44 groups apply. We will be funding and bringing on 6 new networks, and we hope to have that results, excuse me, within the next 2 months. We're planning subsequent RFAs. We're having a meeting on February 28th in Vancouver, bringing together members of REBs and institutional leadership for a full-day discussion on a single national distributive REB model. And again, I really encourage all of our community of trialists to keep pushing within their provinces to state that we really need a single national program. We need the efficiency of that so we can compete on an international level to get more trials into Canada. Having a system where we have each province have an approval process is just not efficient enough, and it makes no sense. We need a single process. We're working on master clinical trial agreements, international captive insurance program, and several other initiatives. The reality is our timeline is short. We have less than 2 years left in the ACT grant. We need to deliver on what we said we would do. We need to collaborate with key stakeholders. We need to think strategically regarding arguments to bring required groups on side and focus on the big picture and move past regional politics. Success, if ACT is overall successful and a permanent, efficient system is implemented and government implements and sustains funding for RCTs, and the Canadian biotech grows and more big pharma and device company trials come to Canada, then the Canadian public will benefit and we will have achieved our goal. I'm now going to switch to my area of focus, which is perioperative cardiovascular clinical trials. And I'm going to focus on a few themes that we've undertaken large trials in this area. So trying to look at controlling the sympathetic system during the perioperative period, the coagulation system, bleeding, hemodynamics, inflammation, systems issues around timing of surgery, and virtual care and remote monitoring. The first big trial that we undertook was the POISE-1 trial. And the POISE-1 trial was a randomized controlled trial of 8,351 patients from 190 centers in 23 countries. And these patients were randomized to either receive a beta blocker or a placebo around the time of surgery. And preceding this trial, there was guidelines saying patients should get beta blockers. There was, in fact, quality measurements in the States where hospitals were penalized if patients did not get beta blockers around the time of surgery. Our primary endpoint was a composite of cardiovascular death, non-fatal MI, and cardiac arrest. This occurred in 244 patients in the metoprolol group, 290 in the placebo group, hazard ratio of 0.84, a result that was statistically significant. However, there was many things we learned from POISE-1, and one of them was real limitations that can happen with composite endpoints. It would be a serious mistake to assume that beta blockers reduce these outcomes. Beta blockers reduced myocardial infarction. All myocardial infarction and non-fatal myocardial infarction unequivocally are reduced when you give beta blockers to patients undergoing surgery. Very effective to do that. However, we demonstrated that beta blockers increase the overall risk of mortality. 129 patients in the metoprolol group, 97 in the placebo group, hazard ratio 1.33. And we also drove up the risk of stroke. And these were very devastating strokes. So a third of people died of the stroke, and of those who survived, over 55% were incapacitated or needing help with everyday activities. And we doubled the risk of these strokes. Insights regarding the negative consequences was that with beta blockers, we drove up substantially the risk of clinically significant hypotension. And we did this on surgical floors. And our research shows that there's delays in recognizing clinically significant hypotension and delays in managing it. And some patients will get into serious trouble. In POISE, it did not appear to matter why you became hypotensive. It could have been that you were bleeding. It could be that you're in heart failure, you were septic. Whatever the reason was, if you were on a beta blocker and you became hypotensive, you were in serious trouble. So insights from POISE-1 allowed us to recognize that perioperative beta blockade has the potential for benefit. It unequivocally prevents myocardial infarction, which is a very important outcome. But there's also the potential for harm. We had an increased risk of stroke and death. It highlighted the importance of clinically important hypotension and the need for large randomized controlled trials, specifically in the perioperative setting, if we're going to understand treatment effects, and identified the need to find a means to safely control the sympathetic system during the perioperative period. Based on this, we next then went to test clonidine in the POISE-2 trial. Now, the reason we did this was that we did meta-analysis work and pilot work where it looked like with clonidine, we had less clinically significant hypotension compared to the beta blockers. And we realized it was the hypotension was the Achilles heel of the beta blocker and the sympathetic control during the perioperative setting. So we hope that clonidine as an alpha agonist may in fact allow us to get heart rate control and prevent hypotension. So in the clonidine factorial in POISE-2, we randomized over 10,000 patients having non-cardiac surgery with either known vascular disease or risk factors. The 30-day outcome of mortality was no different between clonidine and placebo, and non-fatal MI was no different between clonidine and placebo. So in contrast to beta blockers, we didn't see a benefit. At the same time, we didn't see an increased risk of mortality, and there was also no increased risk of stroke. This discordant results between POISE-1 and POISE-2 and two different paths of trying to control the sympathetic system and the mortality discordance likely reflects that clonidine had substantially less heart rate control compared to metoprolol. At the same time, clonidine had less hypotension compared to metoprolol. So in other words, it was not effective in terms of getting the benefit because it probably didn't control the heart rate enough. And at the same time, it likely didn't lead to any excess of complications because it just didn't actually increase hypotension the way that the beta blockers did in POISE-1. So an ideal perioperative sympathetic control may require decreasing the heart rate to prevent MI and avoiding hypotension to avoid death. Wojciech Szczeslik is leading us right now in a large clinical trial testing ivabradine in a situation which may be a pathway for which we can control heart rate without affecting blood pressure, and find this ideal pathway to really get the benefits of controlling the sympathetic system in the perioperative setting. In POISE-2, we also tested aspirin in patients having non-cardiac surgery. And half the patients were on aspirin chronically, that is stopped at least 5 days before surgery, and then were randomized to start aspirin on the day of surgery or placebo. And half the patients were people that were naive to aspirin. They were randomized to start aspirin or placebo on the day of surgery. There was no difference in death or MI between aspirin and placebo. And it didn't matter if you were in the initiation or the continuation strata of the trial. There was, however, an increased risk of major bleeding and even the constant point of major bleeding, life-threatening bleeding with aspirin. So harm without benefit. The only exception to this was an important subgroup that dealt with patients who had had previous percutaneous coronary intervention. And the patients that had a previous coronary intervention, if we look at death or MI, in the no prior PCI group, there was no effect of aspirin. But in the PCI group, there was a 50% reduction in death and MI. Interaction p-value was statistically significant. This likely reflects that people who have prior PCI are more vulnerable to get thrombotic MIs perioperatively than patients who do not have a prior PCI. And aspirin can be very effective in preventing thrombotic MI. The problem likely with aspirin for the majority of patients is that we know from some of the studies we've done with advanced imaging technology using ocular coherence tomography on cardiac cath that we know some perioperative MIs are thrombotic, but it is more common that they are supply-demand mismatch. So the problem is you're likely preventing some events that are thrombotic, but you're causing enough bleeding that you lead to some supply-demand mismatch MIs and have a neutral effect on MI. The only group where this is different is when you have PCI, because then the thrombotic MIs dominate, and that's what it appears to be the benefit. Even though I'm focusing on RCTs, I'll mention just a point here about our epidemiological studies. Two very large epidemiological studies we undertook. One was the VISION study. It was a prospective cohort study of 40,000 patients internationally having non-cardiac surgery. And from those, we developed the concept of myocardial injury after non-cardiac surgery, MINS, which then led to a big trial I'm going to tell you about in a moment. But basically what we recognized is that in patients having non-cardiac surgery, if your troponins go up after surgery for an ischemic reason, your probability of death and really bad outcomes is dramatically higher than if that doesn't happen to you. And this really came from a patient that I saw in the POISE-1 trial that was a very dramatic patient, where it made me wonder how many people we were missing because we weren't systematically measuring troponins. In VISION, we systematically measured troponins in patients. We also then developed the concept of bleeding independently associated with mortality after non-cardiac surgery, BIMS. And the reason we did this is that there's so many different definitions for bleeding perioperatively. We wanted to establish diagnostic criteria that were informed from empiric data based upon prognostic relevance that would be similar to MINS, because frequently we're counterbalancing trying to prevent thrombotic events with bleeding events, and we want them to have the same prognosis. So we tied the diagnostic criteria to things that independently impacted 30-day mortality. We also then developed and identified the concept of perioperative covert stroke in patients having non-cardiac surgery, demonstrating that 7% of patients age 65 or greater having non-cardiac surgery have a new covert stroke on a brain MRI between day 2 and 9 after surgery. And those covert strokes substantially increase the probability of perioperative delirium and increase the risk of cognitive decline 1 year after surgery and the risk of an overt stroke or a TIA in the coming year. And most recently in the VISION cardiac surgery study of 16,000 patients having cardiac surgery, we systematically measured biomarkers in these patients. We developed the concept of myocardial injury after cardiac surgery, which we call MICS. Just the point to make is that the epidemiological research in these two studies was first initiated by patients we saw within our clinical trials, but then they offered important tools for us to then use to then go on to do trials to test. So in this regard, the next trial that we undertook was the managed trial, and this was testing dabigatran in patients who had myocardial injury for non-cardiac surgery. This was an international randomized control trial. We randomized 1,758 patients, and what we demonstrated was that dabigatran reduced the risk of major vascular events compared to placebo in patients who had MINS. And what you see is when you use intermediate dose dabigatran, 110 milligrams BID, there's an immediate divergence of the curves favoring dabigatran. They continue to diverge till about 1 year, remain parallel after this. But what is most striking and important to recognize is that the event rates for these patients at 2 years, they've not obviously plateaued. Maybe they do plateau there, but we don't see that for sure. But these are event rates that are way higher than most cardiovascular research. These patients are on a very poor trajectory for major vascular complications. And dabigatran is one pathway to improve the outcome for these patients, but we need many more. Next, the issue of timing of surgery. This is Dr. Flavia Borges, who we're very fortunate came into the fellowship or postdoc with us and then stayed on faculty with us. Flavia is originally from Brazil, and Flavia was the project officer with me on the HIP-ATTACK-1 trial. And the HIP-ATTACK-1 trial, the impetus for this was 10 years ago. I was consulted to manage a 73-year-old female with hip fracture who had an elevated troponin. And the referring physician had said to me, look, you need to fix her heart before we're going to fix her hip. And despite the best of intentions, the medical management that we initiated with the patient, she ends up having a bleed, she ends up dying, she never makes it to the OR. And this really made me question whether or not this process of medical optimization is really the right path as opposed to doing surgery as fast as possible to see whether or not we can actually improve outcomes for patients. And this then led to us doing research to test whether or not an accelerated surgical pathway may improve outcomes. So we randomized just under 3,000 patients age 45 or greater who were diagnosed with a low energy mechanism hip fracture that required surgery. We had 69 centers in 17 countries, and patients were randomized to either receive accelerated surgery where the patient goal was to be in the OR within 6 hours of the diagnosis of the hip fracture, or standard care, normal timing of surgery whenever that happened. So we ended up having an important differential in time between the two groups. So we were able to achieve 6 hours in the accelerated group, and it was 24 hours in the standard care group. Among patients with hip fracture, accelerated surgery did not significantly lower the risk of mortality or a composite of major complications. There was, however, no evidence of harm even in the subgroup of acute medical conditions who went for rapid surgery. Accelerated surgery did, however, demonstrate it lowered the risk of delirium, it lowered the risk of urinary tract infections, it lowered the risk of moderate to severe pain scores, it led to faster mobilization, faster standing, faster full weight bearing, and shorter length of hospital stay. And we just completed the 1-year economic analysis. It also results in a substantial saving of money at 1 year. We did also identify a very important subgroup, which really was the patient that was the impetus for doing this trial. So in the trial, the patients who showed up and had an elevated troponin with their hip fracture were the ones who had a very big mortality advantage with accelerated surgery. So in the patients who didn't have a troponin elevation, there was no benefit to accelerated surgery. But in the patients who had an elevated troponin, the first thing to know is they have a terrible outcome. 24% are dead within 90 days. With accelerated surgery, it was down to 10%. Interaction p-value was highly statistically significant. From this, Flavia Borges is now leading us in the HIP-ATTACK-2 trial where we're testing accelerated surgery in patients with a hip fracture and an elevated troponin. I next want to move to virtual care with remote automated monitoring technology. So this is Dr. Michael McGillian, who leads this program with me. Mike is a nurse who heads up he's a VP for research within the nursing program, and Mike is a genius when it comes to biotech. First trial that we undertook was the PVCRAM-1 trial, and this was an RCT of patients age 40 or greater being discharged after non-elective surgery during COVID. We randomized just over 900 patients to virtual care with RAM for the 30 days post-discharge or to standard care. We had 8 centers in Ontario and Alberta participate in this trial. In the intervention group, when patients went home, they were given technology that is simple to use. They were given a tablet. They could press the button. They would have access to a nurse and a physician via that tablet 24 hours a day. The technology was Bluetooth enabled, so they put the cuff on, they'd hit the button, it would measure their blood pressure, it would upload onto the tablet. The tablets were cellular enabled, and we would have the data right away. We were able to measure their temperature, their pulse rate, their oxygen saturation, their body weight, and their blood pressures. A really important finding within this trial that I think is a really important message for all of the biotech or remote monitoring technologies is that you need to actually have responses to abnormalities. So in this trial, each center, we told, here are thresholds of which we expect the nurse to escalate care to a physician. So if the blood pressure was below this or above this, if the heart rate is below this or above this, or the temperature is above this. But centers could actually change what those thresholds were. And through an event that happened in the trial where I had a cover I was working at one of the hospitals, or two of the hospitals all the time in the trial, then I had to cover a friend at another hospital, and it struck me that there was a very different approach happening, and I realized there was different thresholds being used. And we then looked, and what we saw was that there was very different thresholds being applied. So there was high escalation centers where 89% of the patients would have their care escalated, intermediate escalation centers where 55% of patients would have their care escalated from a nurse to a physician, and low escalation centers where 34% would have it escalated. And the issue is bigger than this, though, because there's a lot more escalations even within these patients happening. And what we saw was that this resulted in dramatic differences in changes in medication. So 237 changes in medication in the high escalation centers, 124 in the intermediate, and 24 in the low. Virtual visits, same pattern. And what we saw was very dramatic results. The high escalation centers have a highly statistically significant reduction in acute hospital care in the 30 days post-discharge, that is ER visits or readmission to hospital, whereas the intermediate and low risk centers do not, or low escalation centers do not. Same exact signal for brief acute hospital care, that is acute hospital care that lasts less than 24 hours. Exact same pattern for ER visits, substantially reduced in the high escalation centers, no impact in the low and intermediate escalation centers. Hospital readmission follows the exact same pattern. So insights from PHRI-1 was that we saw high rates of acute hospital care after discharge post-surgery. So even during COVID-19 pandemic, when people were scared of the hospital, 27% came back in the standard care group. And in centers with high escalation and management of care, 40 to 50% relative risk reductions in acute hospital care, brief acute hospital care, and ER visits. And it's only credible to expect virtual care with ramp impact outcomes if we identify problems and carers change. And I can't emphasize enough that if we do not put in place care plans of who's going to address the problems in a timely manner, the world's greatest technology will never help us to actually move the needle in terms of outcomes. The next trial I'm going to tell you about is POISE-3, which is tranexamic acid in patients undergoing non-cardiac surgery. We randomized just over 9,500 patients in 114 centers in 22 countries. 99.9% completed the 30-day follow-up. And in this trial, our primary efficacy and safety endpoint, the primary efficacy was a composite of life-threatening major and critical organ bleeding. This occurred in 433 people in the TXA group, 561 in the placebo group. So over 1,000 events with a difference of over 100 events between the two groups. Hazard ratio of 0.76, a result that is highly, highly statistically significant. When it came to composite vascular endpoints, 649 in the TXA group, 639 in the placebo group. So just under 1,300 events and an absolute difference of only 10 events between the two groups. The hazard ratio is 1.023. We had set, and I can be happy to explain why later, we had set a very low threshold for the upper bound of the confidence interval, and it was just above that, so we could not claim non-inferiority, even though the data certainly does not suggest that there's any difference. Other bleeding impacted by TXA, so if we look at BIMS, major bleeding, ISCH bleeding, transfusion of 1 or more units, transfusion of 2 or more units, transfusion of 2 to 4 units, all of these were reduced by 25 to 30% with TXA. Insights from the TXA factorial. Among patients undergoing non-cardiac surgery, TXA reduced the risk of a composite of life-threatening major and critical organ bleeding. Although TXA had no significant effect on major vascular complications, non-inferiority was not established, but our results also demonstrated a 95.6% probability that the primary safety outcome hazard ratio was less than our very low non-inferiority margin of a hazard ratio of 1.125. Dr. Mori Makuchi, who recruited from Italy, who was involved with PHRI with me, and she ran the hypotension avoidance strategy. So in this trial, we also randomized patients to a hypotension versus hypertension avoidance strategy. So there was just under 7,500 patients, and the hypotension avoidance strategy was during surgery. We asked the anesthetist to target a MAP of 80 or greater, and before surgery on day 0 and 2 after surgery to hold ACE and ARBs and continue other antihypertensives based on the patient's blood pressure following an algorithm. In the hypertension avoidance strategy, during surgery, anesthetists were asked to target a MAP of 60 or greater, and before surgery, in the first 2 days after surgery, they continued all antihypertensives, including ACE and ARBs, in these patients. We had 99.9% complete the follow-up. 14% in both groups had a major vascular complication within 30 days. There was no difference between the two groups. The mean difference in blood pressure was less than 1.17 millimeters of mercury, and the heart rate was a difference of 1.4 beats per minute between the two groups. In other words, the hemodynamic differences between these two different approaches was extremely small. And we had no dose effect based on compliance across centers on the effect of hemodynamics or vascular outcomes. The study's significance is that it informs questions very commonly confronting physicians during patients that are undergoing non-cardiac surgery. It appears that MAPs greater than 80 versus greater than 60 is that there's no difference in major vascular endpoints. Greater than 60 appears safe and reasonable. There is a MAP below which you'll be in trouble. We don't know what that number is, but 60 or greater, you look to be okay. And also before and after surgery, holding ACE and ARBs and continuing an algorithm of other chronic antihypertensive medications versus continuing all chronic antihypertensive meds did not substantially impact on hemodynamics and cardiovascular complications. It is likely just the fact that if patients are tolerating antihypertensives chronically, they're accustomed to it and they will generally do well with them. But if the patient is hypotensive coming to surgery, I would recommend that you hold these medications, and I certainly recommend that you don't hold them if they're in the hypertensive side coming to surgery. This is Dr. Amal Bezasso, who you will all know very well, and this is Dr. David Conan, who we recruited from Switzerland, who's in our group. Amal was the project officer on the COP-AF trial, and David then was the PI in the COP-AF trial. So COP-AF was addressing the question about colchicine and the prevention of perioperative AFib and myocardial injury after non-cardiac surgery in patients having major thoracic surgery. We randomized 3,200 patients in 45 sites in 11 countries, and the co-primary endpoints of clinically important perioperative AFib occurred in 103 patients in the colchicine group, 120 in the placebo group, hazard ratio 0.85, not statistically significant. And myocardial injury to non-cardiac surgery showed a very similar result, a result that was not significant but trend in the direction of benefit. But the composite of the two of them was statistically significant. The composite of MINS and clinically important AF, and also a broader composite of major vascular complications, that is vascular death, non-fatal MINS, non-fatal stroke, and clinically important AF was also significantly reduced with colchicine. Safety endpoints, we did increase the risk of non-infectious diarrhea. However, this diarrhea in general was benign. It didn't lead to any hospitalizations or prolonged hospitalizations. And once the colchicine is stopped, as everyone has experience with, in general, the diarrhea will be stopping. So insights from COP-AF is that in patients undergoing major non-cardiac thoracic surgery, administration of colchicine did not simply reduce the incidence of two co-primary endpoints, but colchicine increased the risk, mostly benign, non-infectious diarrhea. There is encouraging evidence consistent with the trends in the cardiovascular research that colchicine reduces cardiovascular events in this setting, and we're hoping that we'll be testing this in a broader population of people having non-cardiac surgery in PHOIS-4. So in conclusion, patients have surgery for important reasons. We should endeavor to improve the safety of surgery so that all patients can have access to surgery. The sympathetic system, the coagulation system, the inflammatory system, hemodynamics, system issues around timing of surgery, and virtual care with remote monitoring technology are all pathways which have the potential to improve outcomes for our patients. Thank you very much.
Wonderful. Thank you so much. There's a clapping in the room. I don't know if you can hear that here. Thank you so much. Really wonderful presentation. Really two part, obviously, as you stated, two very important parts to your presentation. And I'd like to entertain questions if people want to. I will start with people in the room. I don't know if there's anyone in the audience that would like to ask a question. We do have Louise Pilote here, who I see you're very involved in this. I don't know if you have any questions or comment, Louise, if you want to join us here, join me on the podium. PJ, we have Louise Pilote here.
Well, I want to acknowledge PJ's contribution to the ACT consortium and also really helping us here at the McGill University Health Center and the Research Institute to really increase our activity in the area of clinical trials. And I urge you to reach us, Amanda Levato, who's the ACT-CTU manager, to reach us if you have any questions, interest in trials. So thanks, PJ, because your input is really helping us locally to become stronger and play a greater role in trials. I have a question, if I may, about periop medicine. As a general internist, I do practice periop medicine. And
Yes.
in all the trials, I always wonder what's happening intra-op. You will always have surprises that all the anesthesiologists will give 5,000 units of heparin during the surgery, and they monitor blood pressure really well. So what is the impact of the intraoperative procedures on many of those trials that you've conducted?
Yeah, so whole other talk in itself is I have a talk that I give on the sort of history of the real advances in surgery and anesthesia. And intraoperative care with anesthesia has been one of the paradigm shifts that have dramatically improved the safety of surgery. What is interesting, Louise, is that lots of things that anesthesiologists are doing every day in every single case has a really important endpoint or impact on those patients' safety, because the anesthetist never leaves the patient's side. They're managing their vital signs and they're responding to what goes wrong. And as a result of that, we've had over 100-fold reduction in intraoperative mortality in the last 100 years, despite the fact that 100 years ago we did surgery on young, healthy patients with very little comorbidity. And today we mainly do surgery on older patients with lots of bad comorbidity. And that's come from the monitoring and the response of having someone present. And that's what we have to do and bring it into the post-operative setting. A lot of the research, as I was showing, even employs three intraoperative hypotension or intraoperative maps of 60 versus 80 look to be about the same in terms of safety. Intraoperative hypotension in the research is associated with bad outcomes. But what it really is that intraoperative hypotension predicts postoperative hypotension. The intraoperative hypotension itself doesn't actually lead to bad outcomes because it doesn't last that long because anesthetists correct it. But it's the prediction of postoperative hypotension that ends up being very prolonged and poorly managed that results in patients getting into serious trouble. We need to learn from what anesthesia has done in bringing better monitoring technology into the surgical floors, into the home setting, and having perioperative services where people are available to manage things in a timely fashion. So a lot that happens in every case with anesthesia has a big impact, and we need to learn from what they've done and bring it into the postoperative setting.
Thank you very much for that answer. Rita, your hand is up. Do you want to unmute?
Thank you, PJ. My question relates to the subject of renalism, which I'm sure you've heard in conducting all of these large trials. Many times patients with advanced kidney disease are left out of those trials. I wonder, has there been any progress made on that front, trying to get trial generalists to include more renal patients in their trials so that we can extrapolate results appropriately?
Yeah, so I think the upside at the moment for the renal community is that obviously I think any physician who's paying attention recognizes that the renal patients have very bad outcomes. So we should be doing a lot more to help these patients. It's like the hip fracture patients. They have terrible outcomes. I think the upside at the moment with the renal community is that there is more trials happening, so there's now big trials. And the wonderful thing is there's Canadians leading really big international trials that are about to start answering some really important questions. And hopefully that sets the foundation where Canada's going to become a world leader in doing big renal trials. The issue becomes that whenever there is questions, certainly around new drugs, and people are worried about what might end up being the safety issues within populations that have renal insufficiency, everyone gets scared to include these patients. It'd be probably better if they were included from the start, but if they're not, that we at least make sure we're getting trials doing that. So as an example, Pavel Rozhnev, we're just working together right now trying to do a trial with tranexamic acid in people having surgery looking to prevent the bleeding, because these patients are much more prone to bleeding due to the renal insufficiency, yet they get denied tranexamic acid. So I think I'm hoping what I see happening is that at the moment we have a lot of Canadians who are now starting to design and lead big trials that are going to answer questions very directly for our renal population. So there's no ambiguity about the effect within those populations.
Thank you very much. Matthias, do you want to make a comment?
Hello, thank you very much. Fantastic, very interesting, and I learned a lot. I have two questions. One is a more myocardial one. You mentioned that it resonated with me that you think the beta blocker effect is maybe mainly related to a reducing heart rate, but could it be that this is just basically a reporter where we have some good evidence that stress of any kind, the maximum is, for example, is Takotsu or stress cardiomyopathy, causes edema, myocardial edema. Myocardial edema begets microvascular dysfunction and compression of capillaries with diastolic dysfunction and other ramifications. So could it be that beta blockers mainly exert their effect through that? And would it make sense to go into that direction?
Yeah, so I think for sure one needs to be cautious that the heart rate may simply be a marker for something else that's happening. It may not be that. That being said, I actually do think that controlling the heart rate is important. The reason I say that is that in our studies, when we use ocular coherence tomography, we know a majority of the events are supply-demand mismatch. So the more that I'm driving up, supply or demand need to attack a cardia in a very stressful situation, and someone that might have, an unrecognized, coronary artery stenosis, I'm going to predispose that patient to more ischemia and potentially a myocardial infarction or injury. So I think heart rate does play a role, but I think you're raising a great point that it's like a lot of our drugs. We should be very cautious saying there's only one pathway through which they're working. Like ACE inhibitors clearly have many pathways through which we have beneficial cardiovascular effects. But I think what's important is the recognition that beta blockers have an unequivocal benefit to patients perioperatively. The issue is, how do we create safety? And I think it's by understanding the physiology that we're going to get closer to actually solving that problem. And we're still hopeful that beta blockers may come back, that with the technologies that we're moving towards our next generation technology we're about to start studying, we can get continuous non-invasive blood pressure, heart rate, heart rhythm. So perhaps if I had a blood pressure cuff on the floor where I had continuous blood pressure, where I could be alerted very quickly that the blood pressure was starting to drop, as opposed to I'm 2 hours into hypotension before anyone notices it, and I'm way behind the 8 ball in terms of managing it, maybe we in fact could get the benefits of the beta blockers and mitigate the risk, or things like ivabradine, other pathways that might allow us to be successful with this. But the story's not finished yet with beta blockers, and the story is not finished about sympathetic control. It is a very important pathway for which we can help patients perioperatively. And I'm sure you're right that there is more mechanisms than just the heart rate control.
And if I may, the other question I had is related to something completely different. Having been involved in biotech since almost 20 years in parallel, I sense that there is still a certain inertia, or call it reluctance, to get into partnerships with biotech, which for some is still a kind of a dark side. So what do you think are strategies to overcome these restrictions and further foster and promote these collaborations, which I totally agree with you, extremely important?
Yeah. I mean, I think the reality is there's only so much money that's going to exist in CIHR. There's not enough money for all the problems that we confront. There is trials every day not being funded at CIHR, not because they're not good science or not good questions, just that there's such a limited pot. And so, it doesn't make sense for us not to forego other funding opportunities to answer important questions that can allow us to improve health for our patients. The other thing is, I just think as a community, we should check sort of our virtue signaling that we're the good guys and industry is the bad guys. It is not that simple. If we look at just the issue of fraud in research, it is overwhelmingly in investigator-initiated trials, not in pharma trials. And the reason is pharma has to submit their data to the FDA. Investigators don't submit their data to the FDA. And so I think that my experience working with industry is that you typically have really smart people that really know their drug and intervention incredibly well, and they're focused on designing it for very specific indications. And, I think that to deny that as a society, we've not benefited immensely from biotech and from pharma and devices is just to ignore what is just so obvious. And so I think as a community, there's no reason for us to be pretending we're the good guys, they're the bad guys. We're all on the same side. Of course, they want to make money, but at the same time, it's not like all researchers are out there, without their own goals and ambitions, and we can work together in a collaborative way to help patients. And I think we should keep our eye on the ball. Let's not pass up opportunities for helping patients.
Thank you.
Thank you very much for your answer to that, PJ. Charles Kenneth, and then Mark Roger. Charles?
Thank you very much. Fantastic talk. I wish we had all those networks for surgical site infection outcomes. And I don't know if you include any of those in your outcomes, but one of the things in surgical site infection that has come up is how glycemic control during surgery is very important in reducing surgical site infection. How has it fared in terms of cardiovascular events? And is it controlled for in your studies?
Yeah. There's only been small trials looking at glycemic control in patients having non-cardiac surgery. There's been bigger trials in cardiac surgery. The bigger trials in cardiac surgery have not borne out any clear benefits. But that doesn't mean that there's not, because the problem that you have a lot of times in those trials is that the control groups start drifting towards the intervention groups in terms of the management. So you don't see the separation that you necessarily see in just everyday practice. There's no doubt that the diabetic patients have poor outcomes. And I think this is a very interesting area. Like, we've been trying to get some support and funding around SGLT2s, also GLP-1s. We're very interested in both those drugs. Both perioperative SGLT2s are not going to happen immediately, but post, we think that there's a potential value of these drugs in patients. The surgical site infection is a huge issue. So in the VISION study, the three things that end up killing patients in the first 30 days is bleeding, myocardial injury, infection, sepsis. And surgical site infection is a huge issue. There's people in our group that are focused on that. In the VISION 2 study, we have a big focus on trying to understand the pattern when we have continuous blood pressure, heart rate, oxygen saturation, temperature, of what is the pattern of someone who will be diagnosed clinically with sepsis 24 hours from now. We want to try to move back the clock so we only have infection and we never get to sepsis, and try to intervene earlier. Emmanuel Duceppe at CHUM has been leading a lot of work in this with biomarkers through VISION, and it's a really important area. The infection is a huge issue perioperatively.
Thank you.
Thank you very much. Mark, last question for the formal presentation. Mark, go ahead.
Yeah, PJ, thanks so much for your talk. Really enjoyed it. Great to see you, and thank you for your advocacy in the clinical trial space. And I guess, PJ, my question / comment is, to what extent is ACT getting in the policy advocacy space? And I think, preaching to the converted, we know that we're spending over $300 billion in healthcare in Canada, and less than a third of the interventions that we fund have 1A evidence. And are we making the value proposition for trials arguments to the general public, to politicians? The funding envelope for ACT until 2025 is wonderful, but we need to see it grow beyond there and grow in size and volume. Is ACT in that sort of policy advocacy space?
Well, okay, so answer maybe in a couple levels. So one thing is that within ACT, we have very specific communication strategy. We're very fortunate. Emily McDonald with you folks is one of the co-chairs of that. And so there's a campaign at a national level called Be the Cure. It wants to make the public realize that the public can be the cure for diseases that confront both them, their loved ones, and their neighbors. And trying to really turn the page on making people realize that we shouldn't be viewing it as people being guinea pigs, as opposed to opportunities to improve your health, but also for you to be a conduit to improve the health of people that you care about. And so there's one campaign which is focused on trying to change the narrative within the broader society. We're having a meeting just coming up. There's a retreat for the operations committee, Mark, just later this month that is specifically focusing on what should be the next steps within the ACT. So in other words, should we focus on really lobbying government to put in place the systemic changes and funding mechanisms we want? So as an example, if you ask me, if ACT could just do one thing, if we only had a certain amount of money, I would say I would fund a portfolio hospital in this country, similar to what the UK did. Now it embeds study personnel in every community hospital across the country. But we're debating, should we really target government to fund just those programs as opposed to having ongoing funding for an Act 2, which would then also be responsible for the expansion and the continuation of such a program. I think that part of what we have to do is that we all lean to where we're strong and where we're not. Like, I'm not a politician. I feel passionate about science. I'm willing to talk to anyone about science, and I want to conduct science. But I think within our group, we have to give thought to whether or not we even consider hiring, people whose focus is communications with governments, and really helping lobby. We are doing work, as an example, with the WHO. WHO just is going to come out with a very strong position piece for large international clinical trials. They published an article in the Lancet just in December where they call for things based on our input from single national REBs, regulatory processes, et cetera. So there's a lot of things happening at a global level, but I think we need to be much more strategic, and we need ACT is all of us. We need to figure out how to strategically influence all the right people. We're spending a lot of time at the moment, there's a huge focus on trying to get to a single national distributive REB model. And I can tell you, like, the amount of phone calls I have with people, trying to get them on side for this approach. And most people are on side with saying they're not against it, but they want it to be their system, as long as it's their system. And we get into regional politics. And we have to, collectively as a community make the argument, we have to do what's in our collective interests, not what's in the interest of just, small fiefdoms. We have to move past regional politics. Those are tough issues, but ACT is specifically going to hold an RFA later this year for a group to actually create the structure and system to run a single national REB. And we're going to keep pushing on a lot of these fronts. But the point you're raising is a really important one, Mark, and I don't feel like I'm far from being the expert within this, is that we need also strategic help in terms of thinking through how do we lobby the right politicians and, help to create some of the changes that we want.
Thank you. Thank you very much. So PJ Devereaux, thank you so much for this terrific presentation. Really thought-provoking. Congratulations on, there's a lot of work to be done, needless to say. Congratulations on what you've done, what you've managed to accomplish so far, because that in itself is a huge feat. Advancing clinical research, not just in Canada, but internationally. And that we certainly, the team here at the MUHC and McGill, was very happy to continue to support that. I hope next time we can see you in person. We'll bring you in between seasons when it's not too hot or too cold. So we will arrange to get you back here in person. I would ask you, I'd like to thank everyone for joining us today. And Dr. Devereaux, I'd like you to stay in if you can. There are some questions and comments in the chat. So I'll ask you if you could just maybe answer those for the people who've been waiting patiently there in the chat. Thanks again. A terrific presentation, and good luck with all these initiatives that you're taking on. Thanks everyone for joining us today. Have a great day. Bye-bye.